Why did the snake go to the baby toy store? He needed a rattle. He wanted to get a new rattle. Pretty good. All right. Let's see if you get this one. What do you get when you cross a vampire and a teacher? Vampire and a teacher. What? You're close. You're getting there. Blood tests. All right, let's see if you guys like this one. What do you call a person who doesn't pass gas in public? You're like, thankfully. What do you call a girl? Not a guy. That's amazing. Well, I got girls in my house, and I'm telling you, I think they're just as gassy. Okay, what do you call a person who doesn't pass gas in public? And we've determined it's not a girl, so what would it be? A private tutor. Oh, sorry, Max. Max, you just came in on private tutor, man. He's like, I'm completely confused. Okay, so we're in the stride of the semester. We've got pre-quiz that was today. We've got another post-quiz on Friday. We're going to do the Monday-Friday thing. I've met with a couple of you today. We talked over some details on the quiz because you're noticing, like we talked about, that the post-quiz is more challenging than the pre-quiz. So I want to enlighten you a little bit on what I shared today in office hours. So it is intentional that the post-quiz is difficult. And it's not because I'm trying to be mean. It's because I'm actually trying to help prepare you guys for the next phase of your professional career, which is you're going to have access to plenty of information. It's just a matter of, can you find the information quickly, and can you determine if it's quality information? So that's why they're open book, open notes. And so the pre-quizzes, it's very common for you to get, 8s, maybe on average. Many of you are getting 10s out of 10s, which is awesome. You're getting all 5 questions right. Every now and then you have a bad week. Maybe you get a 6 on the pre. 6 is a little low on the pre, to be honest. They should be fairly simple questions. But on the post, if you're not getting 10 out of 10s or even not getting 8 out of 8s consistently, let's talk, but I wouldn't stress. And what's probably happening is you're narrowing it down. Maybe you've got 3 questions that you know pretty confidently. There's 2 that you spend most of your time on the post, and now you're you don't know what the question's asking. We didn't cover it. Some of you are like, we didn't cover that. The post questions, you're going to have a lot of we didn't cover that. But you have access to look it up. And so I want to give you some tips on how to look it up. Maybe there's a certain word you're not understanding. Google that word and see what it means. Find it in your readings. Find it in the lecture and say, oh, that's what he's talking about. Okay? So the post quizzes you're going to work a little harder at, because I know you're going to have to search for maybe validation on what is your gut telling you, what do you already know, how are you synthesizing information. You guys with me? It's an average, so if you take the pre and the post quiz averages, if you're doing really well in the pre quizzes and not nearly as well in the post quizzes, you take the average of that, that's actually okay. And they're weighted the same. It's not like the post quizzes are twice as important as the pre quizzes. The pre quizzes are very straightforward and simple. Another way of saying that is they're kind of easy. So you balance that with the more challenging questions on the post quiz. Okay? Now, on the exam, let me say this. We're a little ways away, but on the exam, I will not ask you questions on material that we didn't cover in lecture. I think I've said that before. The post quizzes, because you can look up the answer, it's fair game. The exam, you're not going to be able to look up the answer. Okay, so I'll only test you on what we cover in this particular environment. Fair? Okay. I believe this is where we left off because I wrote myself a note that says start here. So I think I'm going to back up to get, oh yes, okay. So this is where I remember leaving off, and we finished this slide. And we talked through all the different results if you have ischemia, right? You reduce blood flow, now the tissue is starved, and what happens. And we looked at everything centering around a loss in ATP. And over here, when we look at our pump function, we see an influx of calcium. We see an influx of water and sodium because we lost our pump, because the pump takes energy to run. You think way back when you're exporting sodium and you're importing potassium, right? It was 3 sodiums out and 2 potassiums in for every crank of the pump, and it took 1 ATP to do that. You guys remember that? So that established a slightly negative charge inside the cell because you threw out 3 positive ions and you only brought in 2 positive. That's a net loss of 1. So it creates this slight negative charge inside the cell. Do you guys remember this? That's where it came from. And some of you back then were saying, like, who cares? Slightly negative, who cares, right? Well, that's a big deal. That's actually one of the cruxes of cellular life, is having that slightly negative charge. So if you disrupt that by losing your energy source, you no longer are pumping sodium out, and everything just shuts down. So now we get this influx of calcium, and this is where we left off. Why is calcium inside the cell a problem? And I think as you're walking out the door, as you're nearly packing up, I explained to you, I said the cell spends a lot of energy either getting calcium out of the cell or putting it into packages inside the cell. And if you remember from muscle physiology, where does it put the calcium inside the cell? Bless you. Do you guys remember? It is needed in muscle contraction. You're absolutely correct. So if you're not contracting muscle, you either eject it outside the cell or you put it into what? A structure known as? No? It's not. There is some in the cytosol, but you don't want it there all the time. It's kind of a bag that stores calcium, muscle contraction. It rhymes with reticulum. What's that? Sarcoplasmic reticulum. Very good. That rhymes with reticulum, right? Sarcoplasmic reticulum. So the SR, right? The sarcoplasmic reticulum is where you put all of this calcium. You sequester it into the SR so that it's not binding, as Max was pointing out, and stimulating crossbridge formation. So just an example or proof, evidence that I'm not crazy. Like, you don't want free-floating calcium inside the cell. Well, here's some other reasons you don't want high cytosolic calcium. High cytosolic calcium can be bad when you lose the plasma membrane. That's what PM damage means. That's not referring to the Prime Minister of England. Plasma membrane damage, you get calcium infiltration. And when you infiltrate calcium, look at all of these enzymes that you activate. ATPases, phospholipases, proteases, and endonucleases. So all of these ACEs are enzymes, and so they have enzymatic activity to break something down or digest it. ATP, ACE, breaks down available ATP. Phospholipase breaks down the phospholipids. Proteases break down the cytoskeleton. I'm going to show you a video in the next lecture, and we're not going to watch the whole thing. I'm not going to pass around popcorn. But you can watch the whole thing on your own leisure, and there's some really cool videos of cytoskeletal protein and transportation using cytoskeleton. It'll blow your mind. It's like, wow, this is crazy. So the architecture of the cell, or the structure of the cell, is maintained by the cytoskeleton. It's almost as if you went up into the attic, right, and put away the Christmas decorations, maybe before you came back to school, and you look in the attic and you see all the trusses. That's kind of what the inside of the cell looks like. There's architecture to keep the cell structure intact. And that gets degraded by a protease, which breaks down proteins. Endonucleases, they break down DNA. So if we have a flood of cytosolic calcium, you can see all of the damage that takes place. And ultimately, these two paths, we break down the membrane and you break down the struts that hold the membrane in place, you lose membrane architecture altogether. Make sense? All right, let's look at reactive oxygen species. So ROSs, these are what we call free radicals. And so in this day and age, we're hypersensitive to free radicals. Everybody seems to be talking about free radicals or free radical scavengers. And even in our diets, we're shifting our diet to be focused on how do I include more free radical scavengers so I don't have our antioxidants, so that I don't have a lot of freely floating free radicals, or reactive oxygen species, that are available to go do damage to my tissues. So if you just look at fad diets on antioxidants, or you read labels and people are like, oh, that has a lot of antioxidants. Like, yes, this is the why. So reactive oxygen species, or free radicals, cause tissue trauma. Reactive oxygen species, otherwise known as free radicals, causes tissue trauma or tissue damage, or cellular trauma or cellular damage. Now, we can remove them. We have naturally occurring antioxidants in our body. The ones that are shown here, we've got SOD, which stands for superoxide dismutase. This is found in the mitochondria. We've got glutathione peroxidase, also in the mitochondria. And then in peroxisomes, we get this catalase, which takes hydrogen peroxide into water and oxygen, so it kind of detoxifies it. But let's back up. These are the antioxidants that are naturally occurring. Let's back up and look at this reaction, which is known as this Fenton reaction. So in the mitochondria, if we get the incomplete reduction of oxygen, which can occur, and we've got this situation of a superoxide that can come from all of these situations on the far left of the slide. Inflammation, radiation, chemicals, or what we call reperfusion injury. So what the heck is that? Just for sake of completeness, reperfusion injury is a situation that happens when you're in heart bypass and you put a patient on a heart-lung machine. And so what happens is the heart tissue isn't being perfused with blood. And then the moment you finish the bypass surgery and you put them back on perfusion, you get this flood of oxygen in an otherwise ischemic tissue, and it causes trauma. Okay, so this is reperfusion injury. Reperfusion injury can happen in other situations too. That's an extreme example. It could happen in a situation of trauma, like a patient loses a lot of blood, and so now certain organs are ischemic for a long period of time, and then they're revived. Okay? So these suspicious characters on the left can cause the superoxide situation, which breaks down into hydrogen peroxide, H2O2. The H2O2, through this Fenton reaction, creates a free radical, or a hydroxyl radical, and this is the state of a reactive oxygen species. So what's so problematic with it? What does it do? Well, if you look over on the left part of the graph, you can see that these fatty acids, proteins, and DNA all are going to have some effect with a free radical. It causes oxidation. So when a free radical becomes oxidized, you disrupt the architecture of the lipid. And now you get disruption of the plasma membrane, or you'll get disruption of the organelle that's inside of the cell. If you oxidize a protein, it folds unusually, and then you lose its activity. So if it's an enzyme, it no longer has enzymatic function when you oxidize a protein. If you oxidize DNA, then you start causing mutations. And those mutations could be deleterious to the cell. Those mutations could actually be precancerous mutations, and we'll talk about that in the cancer section. So here's an example of oxidation that you guys see on a regular basis. Headlights on automobiles. There's a plastic. That plastic is basically a polymer, a synthetic polymer, which is organized very similarly to protein architecture. Synthetic polymers are strung together kind of like protein chains. So synthetic polymers or plastics, in some ways behave a lot like proteins. So if you have an older car, let's say it's 10 plus years, you'll notice that your headlights get a little foggy. They're not nearly as clear, okay, as when you first got your automobile. Or maybe they were always that way because you bought it when it was 10 years old. But you know that something changed in that automobile headlight. Well, that polymer becomes oxidized by the sun, And so as it oxidizes, it changes its architecture, and it goes from a translucent material to an opaque material. And that's why your headlights get foggy as your automobile gets older. Okay? Here's another one. Maybe you don't keep your car all that clean, but you notice after a long period of time, you got to clean the inside of the windshield because there's like a film. And you're like, where did this film come from? Right? Like it rains and it snows and there's all this stuff on the outside. Where is this film coming from? Right? Well, that oxidation happens on your dashboard, which is also a polymer. And then it elutes off into your windshield, and it creates a film on the inside. If you haven't washed the inside of your windshield in a while, just take your finger like this, and you'll see a streak. You'll be like, oh, there's the oxidized polymer that Keller's talking about. So just evidence that oxidation is a very aggressive chemical reaction. Okay? And here, we're oxidizing fats, proteins, and DNA. All because of reactive oxygen species. Now, I want you to asterisk this slide and put something. Not in all cases are reactive oxygen species a bad thing, because I'm going to speak out of both sides of my mouth, and in the next lecture, I'm going to tell you an example of how we use reactive oxygen species as part of our defense mechanism. It's a weapon that we use. So you're going to have to wait for the answer to how that works, but you know that it's very potent. And in this situation, it can be dangerous. In other situations, we actually might be able to harness it. And we'll talk about that when we talk about inflammation. The number one call to poison control in America is because of acetaminophen poisoning. Does everybody know what acetaminophen is? The future nurses, this is what you're going to be wrestling with more so than the future doctors, because the nurses are the ones that usually are talking about over-the-counter medications like brand name Tylenol. But acetaminophen is the active ingredient in Tylenol. It's an analgesic. It's a pain medication, okay? And acetaminophen, or brand name Tylenol, is a liver toxin. Let me rephrase. One of the breakdown components of acetaminophen is a hepatotoxin. So the patient takes acetaminophen, and it has a half-life. The liver detoxifies and breaks it down. But if the dose of acetaminophen is too high and one of the intermediates isn't cleared, that intermediate is a hepatotoxin. So the detoxification occurs via three mechanisms: by sulfate or glucuronide, or by the cytochrome P450 oxidase system. The first two account for 90% of the detoxification of Tylenol or acetaminophen. Sulfate or glucuronide, it conjugates to it and renders it non-dangerous. Only 10% of the acetaminophen in the bloodstream is detoxified using the cytochrome P450 oxidase enzyme system. Unfortunately, the breakdown of Tylenol using cytochrome P450 creates this intermediate known as N-acetyl P-benzoquinone amine, or NAPQI. And this NAPQI is toxic to liver cells, or hepatocytes. It will kill them. So what you're seeing in this histology slide is you've got healthy liver in the upper left, and then you have necrotic liver in the lower right. And so the problem is actually, unfortunately, with pediatric cases most oftentimes, because a lot of these like multiple cold medicines that you'll give kids have acetaminophen in them, because it also helps relieve the fever. It'll bring the fever down. So it's an anti-fever med. It's actually an analgesic. So literally, like the snotty-nosed kid is screaming its head off, can't stand it, feels hot to the touch, and just moaning and groaning. You give them Tylenol, and they're running around, okay, and their fever goes down. So it's like magic juice for parents. So they'll prescribe it faster than the label recommendations, and unfortunately, the amount of NAPQI rises. And most parents don't know that they're doing it because they don't recognize, well, I didn't give any Tylenol. I don't know how this happened. Well, I know that's not true. I gave Tylenol twice today. That was it. Well, what else are you giving them? Well, I'm giving them a cold medication, but I only gave Tylenol twice. Well, how often did you give the multi-symptom cold medication? Well, I gave it like the bottle says, like every 4 hours. So now they're getting every 4 hours they're getting a dose of the multi-symptom cold medicine that has acetaminophen in it, and they gave them Tylenol at breakfast and dinner. Does that make sense? And that's how you get here, unfortunately. Yes?
Does a child have a harder time figuring out like their cytochrome P450? Does that system run faster in adults than it is?
Yeah, that's a great question. So the question is, to repeat for the audience at home, the question is the kid's liver system or the cytochrome P450 oxidase system, does it run as efficiently as you and I? And the answer is, of course not. No. It's slower. It's not nearly as methodical. They're a little bit more sensitive to it. Okay. Now, there's some wiggle room, like on the dosing on the bottle. Pharmaceutical companies have some safety margins there. And so it's not as dangerous for you and I to be right on that label. And if you accidentally go over a little bit, you're probably fine as long as you figure it out right away. Don't repeat it the next day. But in a kid, it can happen really quick because of that question. This system is not nearly as efficient. So once it gets to NAPQI, it pairs with a compound known as glutathione, and then it's neutralized. But this takes time for this to occur. Okay. We've talked about cellular accumulations as they manifest with injury. So this slide is highlighting. We've talked about water coming in, right? A lot of the weight of the organ or a lot of the weight of the tissue post-traumatically or post-damage is because of water infusion. Now you know where the water came from, right? There's a lot of sodium that floods in the cell, and then water follows sodium. There could be an accumulation of fat. We talked about that. We could get accumulation of glycogen and proteins in there as well. And what I want to show you now is pigments, different types of pigments. So these slides are comparing and contrasting hemosiderin and lipofuscin. So hemosiderin is shown here in the upper right and the lower left, and both of these samples are liver tissue. These two pictures are not hematoxylin eosin stains. These are actually a stain that identifies the hemosiderin, which is found in iron. And so what you'll primarily see high concentrations of hemosiderin in are bruises. So, whenever you get a nasty bruise and then it creates all these really amazing colors, okay, that's because the blood leaks out of the vascular system. It's in the extracellular space, and the blood has iron in it. And so some of that coloration is because of hemosiderin. And as the hemosiderin breaks down, you're getting different kinds of coloration. It starts out blue and purple, and then it kind of moves to a yellowish color. So in this liver tissue here, and there's a lot of iron in liver, this stain is actually identifying the hemosiderin by these brown dots in this stain. Here in this stain, we're looking at the purple or blue dots. And liver tissue has a normal amount or a expected amount of hemosiderin in it because of a high iron content. But in damaged tissue where it really shouldn't be present, like in a bruise, you're going to have a high level of hemosiderin because of that iron component. Okay. Now, this next slide on the lower right, this is a hematoxylin eosin stain section, and this is of heart muscle. So myocardium. Hopefully you can appreciate the striations in this particular tissue. These purple dots are the nuclei, and the arrows are pointing to these brown stained areas of lipofuscin. And lipofuscin are parts of organelles. So the organelles, as they get older, they'll break down, and they get, if they can't get recycled, their breakdown components have a high content of lipofuscin. And so in an autopsy, looking at cardiac muscle, they can guesstimate the age of the patient post-mortem based upon the amount of lipofuscin in cardiac muscle. So in most of you, there's going to be very low levels of lipofuscin because you're young. As we age, you have more and more recycling of the cells, not because of an infarct, just wear and tear. So lipofuscin is considered a stain that indicates the age of the tissue, or it's an indicator of wear and tear. So one might say, is it normal? Well, technically no, because age is a pathology. So it's part of a normal aging process, but it's not associated with any other disease like a myocardial infarct. Clear? All right, last slide in this particular lecture is looking at back to calcium. So we've got two different types of accumulations that take place in tissues. If we've got a dying or a dead tissue, we'll get what's called dystrophic calcium accumulation. Or we might have dystrophic in situations of like tuberculosis, like what we saw in the lung tissue. So the caseous necrosis in lung tissue with a tuberculosis infection, you may see evidence of dystrophic calcium accumulations in those cells. Or in atherosclerosis. So when we look at cardiovascular disease, and we'll look at that at the last lecture of the semester, in cardiovascular disease, we'll talk about atherosclerosis, and this is where you take the blood vessel and you start getting depositions of fat. You start getting narrowing of the vessel as the patient gets older, and you'll have calcium deposition or accumulations that occur in the vessel. If you take a peek at the announcements, there's some historic announcements. There's a historic announcement from a couple of years back of a sample, a cadaveric sample that we got in the lab, and we were looking at analyzing the stent graft that was implanted. But in order to do so, we had to cut it out. So we got the vessel out of a 80-year-old patient or so, and I took a straight-edge razor blade, one that you get from the hardware store, and did a longitudinal slice to fillet it open, and you can literally hear it cracking, like, and then when you hold up the razor blade, it was clean and pristine when we started, and it's jagged because it's literally so much calcium from dystrophic accumulation as we age in our vessels that it had the hardness of stone. It's like cutting through stone. The picture on the lower right is technically not a blood vessel, but it's very, very similar. In fact, they come from the same tissue embryonically. That is the aortic valve. And the aortic valve here, these are all dystrophic calcium accumulations that cause aortic valve stenosis. And so that leaflet is supposed to open and close, and if it has a lot of calcium accumulation and it gets stiff, that's what the stenosis is referring to, it doesn't close effectively. And so as it's supposed to shut, there's a little space that remains open, and now you get backflow, or what we call aortic valve regurgitation. And that'll cause problems for the patient because the blood isn't moving in the direction it's supposed to move. Okay, indications of dystrophic accumulation. Then the last one on this slide is metastatic, and this is really referring to things that are more metabolic, like in situations of hypercalcemia. So this would be a metastatic situation. So these are patients that have maybe a thyroid disorder versus a dystrophic disease where you've got necrotic tissue or dying tissue. Okay. Here's a review question for us. Let's just kind of take a peek at maybe a test style type of question that you could anticipate. So in this section, the gross appearance of the myocardium shown here from a 58-year-old man who was admitted with chest pain is most consistent with which of the following microscopic changes? Liquefaction necrosis, caseous necrosis, fat necrosis, coagulative necrosis, or apoptosis. So talk amongst yourselves. What do you guys think? Any volunteers to give us the answer and then maybe explain how you got there? Okay, we'll start with, anybody want to brave the answer? Right here? Okay. Okay. Going with D, coagulant necrosis. Who likes that answer? Yeah, very well done. Justification was good, right? It's an organ that was on the list, right? Because coagulant necrosis, remember the tree, the vascular tree, as the blood vessels kind of branch out and you lose flow, you get kind of a wedge-shaped infarct. You walk through the list of caseous or liquefaction. It doesn't really fit the description. A lot of extraneous information in the question, don't you think? Does it matter if they're 58? Does 58 or 18 or 22 matter? No. Okay. Does it matter that they had chest pain? Kind of does. Why does it matter they had chest pain? Nowhere to focus, and you know that there was probably something going on with the heart. I told you it's myocardium, so you know it's the heart, but chest pain means something's wrong. That's not normal, okay? So you're guessing from this question on the microscopic change, and I gave you a picture of the gross tissue, but you may not be able to identify the gross tissue. So actually the picture is extraneous information, right? You guys with me? Because could you answer this question without the photograph? No? Okay, yeah, it's impressive. Yeah. Okay. So some of you, maybe it's valuable. Some of you may not know that looks like a heart. You're like, oh, it looks nothing like a heart, Keller. Okay. But there's enough information here. If you didn't know how to identify this, you could still answer. Do you understand what I'm trying to do? I'm trying to help guide you on how to break down the question. Because what ends up happening is students panic. You get the question and you panic, like, I have no idea what the heck that picture is. It's super disgusting, and he never went over it. Okay? So just pause for a moment and try to do what your colleague just did. Think what you do know. Well, I recognize, the good news is the answer is on the screen. So I recognize these types of necrosis. So you can immediately eliminate this one, right? Because we're not talking about development here. There's nothing to clue you in that this is a programmed cell death. You guys with me? So do yourself a favor. That is definitely not apoptosis. So now I've got 4 that I have to go through, and liquefaction I know is more neural tissue. Caseous necrosis is a lot of lung tissue. Fat necrosis is fat. And coagulative, I have a whole list of organs. What did he tell me? Oh, we're talking about the heart. And then you get to where, okay? Yes? Yeah. Yeah, so absolutely. For some of you, you can kind of appreciate that there is this area here, and it's not a perfect triangle, but you can see that there's discoloration there. It doesn't look like fat necrosis picture that I showed you. It doesn't look like the liquefaction because it clearly doesn't look like a brain, okay? And then it doesn't look like lung tissue, although maybe it'd be hard to discriminate if it's truly lung or not. But yeah, so the picture is not completely irrelevant, but you could still answer it without the picture. Fair. Good point. All right.